Thanks very much for taking a bit of time to watch this on YouTube in some downtime. So my name is Dan Lasserson. I'm a clinical academic. I work half the time at Warwick Medical School and the other half the time in my new job at the Department of Acute Medicine at University Hospitals Coventry and Warwickshire with amazing medics there, whom some of you you'll know through SAM and other networks like Amy Burbridge and others. I've had interest in hospital at home and same-day emergency care for quite a few years. And I'm going to be talking about some work done recently in our SDEC, and our title is perhaps provocatively, seriously, VTE prophylaxis on SDEC. So what I thought I'd do is I'd kick off with let me just share the slides, and then we'll make a start. Right, here we go. Okay, are those showing okay, Will? Yeah, great, okay. So this work was done when I was in my previous role clinically when I worked at the John Radcliffe in Oxford prior to I moved to UHCW. And on the right there, those of you that do point of care ultrasound, as I'm sure many of you are trained to do at the moment, as part of AIM training, you will see that's a pretty large clot in a vessel, and that's actually a great saphenous vein, actually right near the junction with the femoral vein. So that chap got anticoagulated, and that's essentially what we're looking to try and prevent predominantly, lower limb DVT and thromboembolic disease following that predominantly pulmonary emboli. So here's the plan. I thought it's pretty useful to kind of review what we actually know about the benefits and risks from VTE prophylaxis trials, and we kind of take it as read about what we think the effects are. But it's quite useful to go back to original trials and say, actually, what is it that we can say is definitely true from those trials, and what's the remaining uncertainty? And one thing that I hope will come out from this journal club is that a lot of the evidence of VTE prophylaxis was generated before we've had the major change in acute care pathways, particularly around same-day emergency care, acute ambulatory medical care, that is now moving a lot of general medical inpatient work into an acute community space managed by acute physicians on SDEC. And then we'll think about how do we apply that evidence into this new reality. We'll be talking about the paper that we have that Jacob kindly selected for this journal club, presenting the study there, which I undertook with colleagues in Oxford, predominantly from haematology. Susie Shapiro was the lead haematologist on the study. I'd be quite keen to hear your criticisms, what you think we should have done better, and also what do you think this says? What are the inferences? What can we infer from this work? And also, what should we do, if anything, next? So, without further ado, let's just have a review of a few major trials that told us about what VTE prophylaxis can and can't do. So, what's the origin story for VTE prophylaxis? Well, it really kicks off in 1999, just when I qualified, with this paper that compared enoxaparin at 2 doses, 40 mg once a day or 20 mg once a day against placebo. Given for around 6 to 14 days, shows you how long patients were medical inpatients for in 1999. And every patient got a look at the lower limbs. So we weren't waiting for people to become symptomatic. It was basically everyone got scanned, either a venogram, I can't remember ever ordering those, or ultrasound. And the key thing they found was that basically they could reduce what's called a composite primary endpoint. In other words, a mix of DVT or PE or DVT and PE, or whether it's proximal or distal in the lower limbs. And if you give 40 mg of enoxaparin, there's a 63% relative risk reduction. So it goes down from around 15% to around 5%. However, when you look at how many of those were symptomatic, in other words, patients were complaining of something that made us think actually better go and scan their leg, pain, swelling, redness, etc. There's hardly any symptomatic events. In other words, the main reason why the enoxaparin was effective was because it reduced asymptomatic DVT, and the reason we found this was because every patient in this trial got an ultrasound. That's not what happens on the general medical wards. Moving forward a little bit to the next major trial, which was dalteparin. It's called the PREVENT trial. Here they gave it for a whole of 2 weeks, and if you were discharged early, you still had it when you went home. Again, randomized placebo injections or dalteparin, and that showed around almost 50% reduction in the composite primary endpoint without much of an increase in major bleeding. And yet again, draw your attention to the asymptomatic DVT. There's a difference of around 30 events there, and that drives pretty much all of the difference between the dalteparin and placebo arms. In other words, the reason why VTE prophylaxis trials were successful, other than they showed it was beneficial, was because they were scanning people, and the bulk of the events, around 70% of them, were asymptomatic DVT that you wouldn't find if you're just managing patients clinically. So one of the major issues that I think, well, actually, can we reduce mortality? And one trial had that square in its arms called the LifeNox trial. It was a enoxaparin versus placebo, given for between 6 and 14 days, trying to give as much as possible up to 14 days, not always managed. And I've shown the Kaplan-Meier curve at the end, looking at death from any cause, sorry, cumulative events, looking at death from any cause in the day since randomization. Basically, it shows that there's no difference on mortality. It didn't increase in major bleeding, but actually VTE prophylaxis does not prevent mortality. What it does do is it prevents predominantly asymptomatic low-level DVTs. And that could be important in itself. That may be the generation who knows of future venous ulceration in older age. We see plenty of that on SDEC and acute take. So, and obviously, if you're offered a choice of having or not having an asymptomatic DVT, you'd probably rather not have one, I'm sure. But actually, that's what it appears that VTE prophylaxis is stopping. And the fact that this notion of does VTE prophylaxis in hospital affect mortality has been looked at with something called a network meta-analysis. This is where a bunch of all the trials looking at VTE prophylaxis are trying to kind of compared head, not really head to head because they weren't compared head to head, but the modelling tries to compare them head to head. And essentially, it shows that no intervention, whether it's unfractured heparin, low molecular heparin, the pentasaccharides like fondaparinux or the DOACs, nothing will actually reduce mortality when you look at it for VTE prophylaxis in hospital. It will reduce predominantly asymptomatic events, and for if you do a lot of trials together in a formal meta-analysis, you can actually show that you will reduce some symptomatic events too, but it's a small effect. So a little more about why we worry about this hospital-acquired thrombosis rate up to 3 months, because that's kind of, again, as a forerunner of why we did our study. This was a cohort analysis actually done in America, in Vermont. And essentially, the guys working at this hospital in Vermont looked at all the patients who were in the hospital's healthcare system, so whether they're in hospital or primary care. And it looked at what's the risk of VTE in patients who had no hospitalizations, and compare that to patients who were in hospital and then month 1, month 2, and month 3 after discharge. And actually, the hazard ratio, which is the column in the far right column there, shows yes, highest risk during hospital, but it's high from month 1, month 2, and up to month 3 after discharge too. So essentially, until you go after month 3, you're at increased risk of thrombosis, and that's why our hospital-associated thrombosis time frame is 3 months when our HAT teams look at patients in that follow-up after acute admission. So, can we use DOACs instead of low molecular heparins for inpatient VTE prophylaxis? It would save a lot of time and injections of nursing time. The Magellan trial, 2013, compared 10 mg a day of rivaroxaban, which is, it's not a licensed dose, but it's one that's been used in all the trials for VTE prophylaxis and also used a lot in the, there's a big literature on trauma and arthroplasties and the like from our orthopedic colleagues, which is separate to the medical. And I'm just going to focus on the medical inpatient bed base because that's relevant for us. And it shows that around at 10 days, rivaroxaban 10 mg once a day is equivalent to enoxaparin. So we're not looking for it to be better, we're just looking at it to be just as good. But the major bleeding rate is increased from 0.3% to 0.6%. So it's doubled, but at a very low level at 10 days. And again, on the far right, looking at up to day 35, because it's looking at extended use of DOAC. Again, rivaroxaban looks better than enoxaparin, but only if you look at the asymptomatic proximal DVTs. Again, the big difference between the rivaroxaban and enoxaparin in that far right column there for day 35 outcomes, pretty much all that difference is driven by asymptomatic proximal DVT. In other words, hauling patients back in 35 days for lower limb ultrasounds just to see if they had an asymptomatic DVT. So no difference in terms of symptoms, but difference in terms of that asymptomatic DVT rate. So, and the literature has gone in a certain way. Rather than doing more DOAC trials for inpatients, they've tried to say, can we reduce this post-hospital discharge VTE risk? So DOACs are oral, easy to deliver. So it feels like it's the right kind of intervention if you wanted to try and reduce VTE risk after hospital admission. And so several trials looked at giving DOACs as inpatients and then continuing for about a month, more or less, after after an acute medical admission. And this, and so Zander Cohen and Beverly Hunt made this really nice figure actually to look at a few of the extended VTE prophylaxis trials. One on the far left, Exclaim, that's actually just using enoxaparin for a month or so, and the others, Adopt is apixaban, Magellan, rivaroxaban, and then there's a new kid on the block called Betrixaban, not that new because this was a 2016 trial called the Apex trial, but Betrixaban looks like it may have a slightly better profile in terms of benefits and harms. But essentially, all the evidence suggests that you can at least get as good an effect with DOACs as low molecular heparins, but there is a risk of an increase in bleeding risk as a result. So there's a benefits and harms definitely for a trade-off in DOACs in that out of hospital space. So how do we apply then this trial evidence? Because, we've got up to 2016 or so, but actually a lot of acute SDEC kind of took off 2015 afterwards. And we're all doing it now, trying to get as much as this fabled rate of 30% of the acute medical take or more managed outside hospital without a medical bed. So how did patients get into those trials? Well, the age is variable depending on the trial and the risk factors present. Other risk factors got recruited with things like having a previous VTE, but not currently anticoagulated, and the acute medical illness. So heart failure, that's managed a lot now on an ambulatory basis in acute phase. Acute infections, again, that's a lot of stuff on SDEC. The acute inflammatory syndromes, they still have flares of autoimmune diseases, and there's something called respiratory failure not requiring ventilation. So patients who are hypoxic but not getting ventilated, perhaps more tricky in the SDEC space, but some people do it, and patients not in critical care. So we can certainly map some of our SDEC activity onto that, and those patients who perhaps would have been admitted in 1999 or more in those trials, perhaps now being managed as an outpatient. So if we look at the full definition of what SDEC is, according to the SAM and RCPE standards from a few years back, so allows specialists where appropriate to assess, diagnose and treat patients on the same day of arrival who would otherwise have been admitted to hospital. So in other words, patients that without this infrastructure and heavy use of acute physician thinking would otherwise need to be in a bed, i.e. they would have been in those previous trials. So the kind of question that I thought of then, and that far right little graph there shows a typical SAMBA output, looking at the percentage of the acute medical take managed managed through SDEC, and some aren't doing it at all, and some are doing almost all of it. Those are rather unusual units, but most of us are in that, in the middle, where between 20 to 40% plus of our medical take is being managed by acute physicians on SDEC. So if these patients are all bona fide admittable, then do we need to give them VTE prophylaxis? That's a question that was coming to a number of us who were kind of thinking in this space. So, and that begs the question, well, is the modern SDEC population truly high risk for VTE? We see a lot of patients that perhaps would absolutely not be admitted. So some of those uncertain chest pains that need an assessment, plus or minus biomarkers, and most of them get reassured and discharged. That's probably not admission territory, but there certainly is something there. So we thought we needed a study that would assess VTE risk in SDEC patients. We wanted to capture that prolonged risk duration seen in the hospital-acquired thrombosis. We know it's highest in that first 6 weeks, but that risk period does last for 12 weeks. And also, could we compare with the VTE risk in patients admitted acutely and managed through bed-based care? Now, that's a different cohort, obviously, but we do want to try and benchmark what's the VTE risk in that SDEC population and looking at the contemporary in-hospital population. And that's essentially the kind of background and context why I did this study. So we routinely collected data from 5 years of SDEC activity. So it started in 2015, but in the hospital I worked at, I don't know, those of you who kind of had to develop new services, often NHS hospitals, they kind of obey Newton's laws of motion. The first law of motion is for every action, there's an equal and opposite reaction. And so when you're trying to set up a new service, there's a bit of pushback. So after a few months of perhaps classical Newtonian mechanics, we thought it's safer to go from April 2016 as the kind of full-throated hospital home, full-throated secondary emergency care until March 2021. So 5 years of SDEC activity, and we use Cerner EPR, Cerner Millennium, to get as much of data we can to describe this clinical cohort. So it's routinely collected data, not research data, and primarily collected with all those biases, which we'll talk about, and again the clinical outcomes, which we'll go through the methods. So who were this patient population? How did we decide that they were in this retrospective cohort? Well, they had to attend our SDEC and not be directly admitted. Obviously, those patients would go on to get normal VTE prophylaxis as part of their inpatient care predominantly. And we said, well, look, we know that a lot of patients do come back to SDEC, sometimes programmed, sometimes not programmed. So any subsequent SDEC attendance after that index attendance within 30 days, we thought we'll call that the same acute care episode. That tends to be where people think in the literature about a readmission being part of the initial episode. Sometimes it isn't, but when you're looking at retrospective data at this scale, you've got to put a line in the sand and say this rightly or wrongly. So if anyone came back within 30 days, we felt it's part of the same episode. So we kind of, the clock went back to that first episode, as it were. And obviously, we're very reliant on diagnostic coding, given this was a retrospective large-scale study. We excluded patients where VTE was reason for attendance. Also, a lot of patients come to SDEC with a suspicion of VTE. And so where there was a VTE diagnosis, we excluded them. And also, we were able to look at comorbidities for risk factor association with VTE, and we'll talk a bit more about that when we present the data. So what was our outcome? What was the outcome? What were the things we're trying to predict? So it's coming back with a symptomatic VTE. So again, it's retrospective, it's normal routine healthcare. So we are not doing systematic ultrasounds at days 10 and 35, like in those trials, looking for a symptomatic DVT. This is symptomatic VTE. And they could come back to SDEC, they could come be admitted on the acute medical take, they could be seen in outpatients, they could come to the DVT clinic. So basically, they could attend any portal of entry, if you like, into our hospital system in the 90 days after that index SDEC attendance, ignoring any reattendances in the next 30 days. So our outcome was it was a symptomatic VTE where the patient acted on those symptoms, came to healthcare, and healthcare did a diagnostic test. So there's a number of steps in there that have to kind of come in order for us to get our outcome. We took 90 days. We could match the hospital-acquired thrombosis timeframes. Obviously, sometimes people come to SDEC and it's not clear what's wrong, and then within a day or so of tests and things, it is clear what's happening. So we took a decision that if within 48 hours that there was another SDEC attendance with VTE diagnosis, even if the first one wasn't VTE, we thought, well, that probably was all due to VTE and perhaps the symptoms were a bit unusual to begin with and it wasn't clear what was happening. So if patients had VTE, they weren't part of our cohort because we're looking at an acute disease process that could result with VTE. And that was, we thought, our best way of trying to capture that cohort through retrospective data. So, results. So that 5-year period, there were 45,000 episodes of care, right? And we excluded of those around 4,000 because that was the patients directly admitted from our ambulatory medical unit. We excluded another 1,300 because VTE was a coded diagnosis of SDEC attendance. So they weren't admitted, but we diagnosed VTE or DVT or PE. And they were managed without admission. So they come out of the cohort as well, excluded. And there's a handful of patients over 5 years, 10 a year or so, where actually they presented with something and it wasn't clear that it was VTE, but that was diagnosed within 48 hours through other tests. So it's a small number as well. So we thought that was our best way to get effectively the cohort that's at risk of VTE that doesn't have VTE when they come to SDEC. So that leaves us with 40,000 odd episodes of care. And obviously, patients, as we know, do come back over the course of 5 years. So it's about 33,000 patients with individual patients had those 40,000 episodes of care. So many had one, some had quite a few, and one or two had a few others. So some tables to sort of go through a bit of who these patients were. So average age of 60 on these 33,000 individuals. Again, the usual male-female split of an acute medical, acute medical group where there's older age adults, where you'll find more women than men. I'm not sure how accurate those weights are in terms of looking at average weights, but there we are, average 72, which probably reflects what people tend to write rather than, I think, formal weighing. And the comorbidities, the things that might drive risk. And as you know, this was done in Oxford, so you can think about how the difference that is where you work. So a 2.4% obesity rate is low nationally. And we are kind of stuck with some of these problems of coding. So this isn't us using a data dictionary to say what we think. So you've got disease of the circulatory system is a massive catch-all. But we do have separate things like ischemic heart disease or CVD, inflammatory arthritis, and IBD, etc., and AF. And around 10% of our total cohort had a current use of anticoagulation, or a current prescription of anticoagulation. How much that was adhered to, we didn't formally assess. And again, that's the limitations of using observational data. You're reliant on what's recorded, and particularly at large scale, where you're not able to read 33,000 separate entries on EPR, you are reliant on the coding, which can be quite coarse, shall we say. So a little bit more about this population overall in SDEC. So around 5 hours average duration on the unit, and about 10% of patients had more than one SDEC attendance. And again, the trouble with the coding is that in observational data is you can have a little bit of a handle on why patients are turning up with problems in the respiratory system, circulatory system, but it's not as good as having formal diagnostic criteria, which again is a bit of a limitation of Cerner and how things are coded and what we have access to. But a formal research study does not have those things. And some average things. And 33,000 patients, what an average CRP means, I'm not sure. But there'll be again a substantial mix of patients who are normal but with a concerning symptom are assured, and also on the other end of the spectrum, some patients who are quite unwell, who through their choice or because we can safely do it, then manage on an SDEC basis. And overall in this 3,000 patients, death within 90 days of SDEC, it was 4%. So again, a little sense of the difficulties of using observational data, but you can get a sense of how it maps to where you work. So results. So VTE within 90 days. So there were 349 events, and that we put that 0.9%. So the denominator I put the number of episodes rather than individuals, which is a kind of, I think with observational data, it can be quite easy to overplay your hand. So we're keen to, when we make assumptions, it would be to kind of bias things towards the null rather than to overinflate the case. So if there were 40,000 SDEC episodes, even though some of those patients may have those episodes more than once, we felt that it was events per episode was the sort of the safer statistic to use rather than events per individual, which would make it over 1%. So it's 0.9% of patients had VTE within 90 days. And the median time was around 29 days. So the histogram on the left shows that actually pretty flat, that risk curve over those 90 days. But either way, it's still much higher, much higher than the population rate. So the population background rate is much lower than what we're seeing there in that histogram over time. And the median 30 days is actually longer than you find in patients. We'll talk a bit about that perhaps in the discussion. And it's as you can imagine, for the kind of problems that might be driving VTE risk, they're also driving mortality risk as well, particularly cancer. So although the overall cohort had a 4% mortality risk at 90 days, in those patients with a VTE diagnosis at 90 days, it's 21%. We don't have data on the mortality and why, but again, a formal study would be able to do that. The observational data does not allow us to do, really. But anyway, that's an interesting pattern. So it's around 1% VTE risk is in the cohort, and this as a cohort itself has a high mortality rate. So now, like many of you, I'm sure on the SDECs where you work, you'll get a VTE pop-up. So we thought it'd be interesting to look at those patients that had DVT or PE diagnosed. What was going on at their risk assessment if you wind the clock back to that index SDEC attendance. So of those 349 people who had DVT or PE, around 40% had a VTE risk assessment completed. So there's a recommendation to prescribe low-molecular heparin. That outcome was agreed, but we don't have discharge data, and we know from the unit that we didn't send people home with it. So they might have had something at the time, but when they went home, they did not have an outpatient prescription for dalteparin. in about 16% of patients, they said, we'd like you to prescribe it, and that was disagreed with by the prescriber. And then going through the various bits and pieces on the risk assessment, another 10%, it was not indicated anyway. So it just shows the difficulty in an SDEC space of using a tool that's designed for hospital inpatients, and is designed around a binary choice to give a once daily injectable that's new for the patient, and how the complex that would be if you wanted to go down that route, if you're thinking about acute ambulatory VTE prophylaxis outside hospital. So can we identify patients at risk of VTE? So this is essentially a regression to say, can we pick at those 350 odd patients out of the 33,000? And on the left, we've got the univariable analysis. So that's where we just test one variable at a time. And the multivariable analysis, when we put all the variables together to say which are the ones that stand out. And the ones that are in bold are the ones that are statistically significant. And this is after making what's called a bomb-friendly correction. In other words, if you have a p-value of 0.05 and do 20 tests, one's going to be positive, whether it's real or not. I mean, you made that correction so that the ones that are positive are indeed, you can rely on that. It's not because we've just done loads of tests and we've come up with some stuff. So when you look at the reference ages there in the top few rows there, so if it's under 40 years, as you go up, the risk gets higher with older age. That's not a surprise, but at least that fits with what we know already. Cancer, unsurprisingly, comes out as being a big risk factor. And again, this coding problem for history of disease of the circulatory system, unclear what that means. AF is separate. But again, and we're not sure, is that peripheral arterial disease, peripheral venous disease, is it coronary artery disease, or or atherosclerosis somewhere else in the vascular tree? Unclear how that coding is used. But again, if you were to do a trial, we could decide what's what, and pick patients out perhaps a bit more accurately. And then looking at this VTE risk assessment completed, no risk. But then this bit of the one that intrigues me a lot is one or more attendances. And that says something around complexity, acuity, and the high risk that comes from that acuity and complexity. If you need to come back several times for your SDEC journey of care, either you're needing multiple days of parenteral treatment, or perhaps you come back for cross-sectional imaging. It's an indicator of acuity and complexity, I suspect. But obviously, when you're seeing someone on day one, you can't say, oh, you're going to need 4 or 5 attendances. So, or why it's a useful retrospective one, it's perhaps the least operational on day one, because you don't know how many attendances this patient's going to need until you've seen them several times, I guess. But something around acuity complexity, I suspect, is what it's telling us. So the other thorn in the side of some of this work is around nothing's ever pure in real life, whatever the models tell you. And this Sankey diagram, so big thanks to my work with Samba and Sam, because it was working with Samba, the Society of Acute Medicine benchmarking audit team, that first got me into Sankey diagrams as being a really helpful way to understand patient journeys. So patient pathways are complex, and SDEC is no exception. And this on the right, this diagram shows that actually some patients had a prior hospitalization before their index SDEC episode, and that may have conferred some risk. Also, some patients after their index SDEC attendance had a hospitalization afterwards too. Again, it's real life. And we don't know the extent to which those hospitalizations, either pre and post that SDEC attendance, contributed to VTE risk. So is this a pure SDEC cohort, as pure as we can get? But in any pure SDEC cohort, because it's real life, patients will be in hospital beforehand and they'll be in hospital afterwards, even up to 30 days, and up to 90 days, possibly something else. So someone can have a completely different condition after 30 days and get admitted as an inpatient. And that may have conferred some of the risk too. So, and again, as I've already said, getting full risk factor profiles is difficult due to coding, and getting full diagnostic data is difficult due to the way in which coding occurs in our version of SONA. Many versions of SONA that may do this better. Also, the other thing is that we may have underestimated the VTE risk if patients went to other hospitals. So we're assuming a bit of brand loyalty here by our SDEC cohort. Did they come back to John Radcliffe Hospital or the Horton in the north of the county? Or if they lived in the sort of southern area, perhaps they went to Reading, or if they live in our more eastern fringes, perhaps they went to Aylesbury, or even, who knows, even Milton Keynes if they're far north. So there may be a bit of what you might call diagnostic leakage at the edges. But again, for observational data, I think, again, we risk, as I say, we don't want to overplay the hand. So actually being as cautious as possible is probably a safer bet. Also, some patients had a sudden death from PE, for example, and didn't come to hospital, or went to ED and then became a coroner's case. We wouldn't have access to information. So if there were any fatal PEs, then we wouldn't know about it unless they'd been admitted before that happens, or contact and diagnosis before that happens. So what can I say as a discussion? Well, I've got a couple of slides to pick up things, but I'm really keen to see what the group thinks. But I think, or we think, having looked around, this is probably the first study of symptomatic VTE associated with acute ambulatory care. And we think it's about 0.9% at 90 days. Does that matter? Well, it's similar to the symptomatic VTE risk in high-risk acute MR medical patients. So that PREVENT RCT that was done in 2004, looking at enoxaparin versus placebo to try and reduce deaths, actually, that was their risk around for those patients who were inpatients, and around 0.9% was the risk in their patients who'd had enoxaparin as inpatients. Also, there's an observational study called IMPROVE that was published in 2011 in Chest, and their VTE rate at 3 months is around 1%. So we feel that actually, roughly at 1%, we're kind of there or thereabouts with an inpatient cohort, even though these are SDEC patients where NICE is silent about whether or not we should be giving VTE prophylaxis. NICE is completely silent on this issue. It usually is when it's tricky. But also our 0.9% we found is higher than observational studies of general medical inpatients. So this is AUH data. Again, huge thanks to Susie Shapiro, the lead hematologist on this study, working with me very closely. So our HAT rate for our inpatients at the John Radcliffe is 0.55%. So that's roughly, I suppose, almost half, which is just over half of our VTE rate that we found in our SDEC cohort. And obviously, those patients are, for the vast majority, will be given low molecular weight heparin prophylaxis. And the early trials tell us that we expect roughly around 50% reduction in VTE with low molecular heparin prophylaxis. So effectively, you could say that if it's 0.5% as an inpatient with prophylaxis and 0.9% as SDEC without it, the risk in the SDEC population is pretty much the same as the inpatients, but it's halved because we're giving low molecular prophylaxis. So we're kind of seeing what the trials would tell us we would expect: a native rate of around 1% reduced to 0.5% if you give everybody VT prophylaxis. And there's a similar lowish rate in that Canadian observational study I showed you earlier, 0.4%. So the other things to point out, probably the pattern of timing is a bit different. So again, that PREVENT trial, the median time to diagnosis was 16 days. In ours, it was higher. And again, we also saw that steep decline for our in risk as well over. Sorry, you saw the steep decline in risk in the observational studies of inpatients that showed you from that table, but in ours it was more flat. So it feels a slightly different pattern of diagnosis. The rate at which the events are happening feels slightly different in this cohort to inpatients. But key risk factors are similar: age, malignancy, circulatory disease. Again, hard. You need to unpick a bit what that means. And again, this interesting finding that it's having several SDEC attendances as part of your journey within 30 days picks out patients at higher risk. Something about perhaps new diagnosis of malignancy, complexity, heart failure, acute infection. Those all fit with that cohort that were recruited to those very early trials of VT prophylaxis. So I think that's my bottom line conclusion. We'd expect a 50% reduction with heparin prophylaxis. We observed an inpatient rate of 0.5 and a rest rate of 0.9. So it feels like that the SDEC population has almost the same risk as the inpatient population. And the difference in things is because the inpatients get low molecular heparin and our SDEC patients do not. So I presented this at Sam Brighton in November, and discussions centered around what happens with these data. Do you want to repeat it at the centres? It feels like we can't just, the VTE pop-ups are already happening. We're observing this rate. So I don't think VTE pop-ups really help. And we wonder whether a trial is needed. So I guess the questions I'm interested in, not just, what do you think we could have done better in the trial? You know, is there equipoise for a trial? If you see patients in SDEC, you think, well, I'm not sure if say a number of days of a DOAC, if patients can have a DOAC, are beneficial or harmful. You know, yes, we know there's the bleeding risk from DOAC is higher than low heparin. I don't think low heparin is an option for SDEC prophylaxis. It's just a huge volume of patients, and think of the costs and things of having to send them away with, you know, 7 days of needles and a yellow plastic thing for the needle bits afterwards. If we, you know, would acute physicians recruit to a trial? Are acute physicians in equipoise around it? It's a pretty high-paced unit, isn't it, SDEC? There's a lot of patients, you've got to see them quickly, and that's the same with all the SDECs I've worked in. Is it feasible in a high-pressure paced unit to do a trial like this? Can we identify a group that has this high risk of VTE? Could we identify a group that has a high risk of bleeding? We might think we might not want to recruit them to a trial, because it's clear that the DOAC bleeding rates are a little bit higher. They're low, but they're definitely a bit higher than limit heparin. And also, if we can establish what those risks of bleeding are, and ultimately, you know, could patients decide supported decision aids, and could it be cost effective? So before I go on any further, maybe that's a good point to sort of stop and see what the room thinks. Jacob, I might just stop sharing just so that I can see whose hands are up.
Yeah, thanks, Dan, for this really, really good presentation. It's I bumped into the paper because I read the journal Thrombosis and Hemostasis out of thrombotic nerdery, really. And I thought it was pretty shocking data, to be honest, because when I'm sure your CERN is very similar to us. If we do a VTE risk assessment for a medical patient, the first question get asked is, are they going to have a reduced mobility, yes or no? Now, the buzzword is ambulatory. We still call our department ambulatory care, and patients on the whole might be a little bit less mobile than usual, but are still functionally independent. And you wouldn't necessarily label them at high risk of VTE because of mobility. So have we had all wrong? And it's primarily driven by acute illness. And it really sounds like that hypothesis is sort of being answered by the study to some extent, because very few patients in your cohort will have been significantly off their baseline to mobility, because otherwise they would have been in hospital being supervised to the toilet by staff nurses on the AMU or long stay wards. So it's fascinating how it quite possibly tells us a bit more about which bits of Virchow's triads are at play at causing hospital-acquired thrombosis. And I thought it was utterly fascinating and vaguely disturbing too. So do we need to revise how we risk assess any patient for hospital-acquired thrombosis?
So I think the prevailing teaching has been, hasn't it, that it's mobility, but I think that's a kind of perhaps a sleight of hand, because all the patients, we've only ever done the work on patients who are inpatients, and they're kind of all in beds. And for those of you who've been inpatients in hospital, including me, you don't really want to walk in hospital. The bed's the wrong height, the floor's concrete. You're ill, you want to lie in bed. So I think there is something about that. We've presumed it's immobility because of what institutional care effectively makes it easier to do while you're an inpatient, right? Rather than think it's maybe more about what's circulating in the blood. What are those acute changes? You know, all those cytokines running around in acute illness, or the changes in flow associated with hypervolemia and heart failure. So it may be those elements around Virchow rather than anything to do with immobility. And I think that's kind of what I kind of take from this data is I think it's about the acute illness donates the risk, and the mobility is maybe neither here nor there, really. It's actually what's the acute illness driving this. And I wonder, that's why I feel like an SDEC would be interesting if we could perhaps take out the patients that wouldn't ever get admitted to hospital, but we see on medical SDECs anyway. And where are those patients that we're taking a bite out of the acute bed base and managing those as ambulatory? And that's where I think the risk is. And that, out of interest, I've had the same heated arguments with colleagues of mine that do hospital home, going, well, you know, they're at home, you know. I said, yeah, but they're acutely ill, and they're baseline mobility. It doesn't matter, you know, the CRP 300 and the creatinine's 500, and you're giving them antibiotics and fluids, and you know, as an inpatient, they definitely get it, and these patients probably are really high risk, right? So And I suppose I think is also interesting, and I'm going to do some work with Thrombosis UK as well to find what people think, because I think the bulk of what it is, and I'm looking at your comment there about death. It's pretty hard to prevent death with VT prophylaxis, but you can absolutely prevent some symptomatic events, around half of them, and you will prevent a lot of asymptomatic events. So for every symptomatic event you stop, there's probably 10 times that number of asymptomatic events. Who knows? Maybe that's the cause of all those venous ulcers. Who knows? Not sure. Will, your hand's up.
Yeah, which is really, I think I may have missed the point slightly, but I think I was interested in, are we giving too many patients in hospital low molecular weight heparin VTE prophylaxis? And if we were to take into account the financial cost of that and errors associated with low molecular weight heparin and the work burden for staff, and that, I guess, I know this was mainly about SDEC, but it was that was going through my head, I guess, with that data. I don't know whether that's answerable right now, but
I think there is I mean, all the trials showed an excess of bleeding if you give VT prophylaxis, and all the trials are at pains to kind of go into the detail, particularly if there's fatal bleeding events. And usually the fatal bleeding events are in the context of advanced carcinoma near an epithelial surface that was, and they may have triggered slightly more bleeding. But it was felt that certainly when you read an in-depth trial, it's quite interesting preparing for this and also looking at the data, reading back over these trials and going, actually, there is no mortality benefit, but there's definitely an event benefit. I think that the data wasn't used to say how do we look at, not like a has-bled approach. Thinking about, yes, there's data showing around stroke, definitely fabulous reductions in stroke risk if we anticoagulate in this context of AF plus other risk factors, but also taking into account the nuance of the bleeding. That approach was never taken for hospital inpatients. Maybe that's a scale issue, because if you're admitting 100, 120 patients a day, doing nuance scores when you've got a long take list to kind of do, perhaps it's just not feasible, or the way in which the research data was operationalized via NICE and via national programs, that was never the issue. Partly thinking, look, it's low dose, it's a few days. But there is, even with a low dose and for a few days, all the trials showed an excess of bleeding, but it's low rates. That's where sometimes looking at those odds ratios is a bit misleading, because the odds go, hang on a minute, there's an OR of slight benefit for this, but there's an odds ratio of 2 here for bleeding, but you're going from very, very low base double to a slightly higher base. So that's why, again, presenting everything as odds ratios, as happens in this network mesh analysis, doesn't necessarily give you a true idea of, look, what's the risk. If you were to have, smiley faces and non-smiley faces and numbers and get a sense of that may be more helpful. But I think there's been certainly an absolute absence of patient decision tools in this area, and that I think would be quite useful, particularly if we're thinking SDEC may be an area that we could go into. Yeah. So, but any thoughts, anyone about actually which one? I just go back, because the last few questions I got about. Let me just share, because the last thing is around a quick right. Okay, so yeah, so there's a QR code there, and I want to again make sure that people have a chance to just answer that. And that's because I kind of want to know that if do you guys think this is an important question? If you think it's not, then fine, it's not. But I'd be really interested to know what people think, given that almost all of you, I'm sure, will see a fair number of patients in SDEC as part of a job plan across Acute Medical Unit, Edin, Reach, SDEC, etc. You'll see high volume SDEC patients, and given we've got these data, is it an important question anyway? And the second thing, I suppose, is around, do you have equipoise? If some of you go, I'm never going to give prophylaxis, fine, or I'm going to give it to everybody, or in the middle going, look, there's risks and benefits, I'm uncertain as to whether we should do so, are you in equipoise? And the last question is, if we were, it would be a tough one to get, but if I could get funding for a trial and it was out there, would you recruit to it in your unit? Is this something that you think actually we want to know the answer to? And would you support us if we went for a trial? So those are the kind of, I guess, 3 things. And there are no wrong answers, right? Because it's, again, we've done acute ambulatory medical care for over 10 years, pretty much, without doing this. And I think it's only in the advent of highly of having had an EPR for a number of years that we've been able to look at this. Or do you think we need more data? Anyway, so be interested in what I think, and then certainly people who are looking at this as a recording, be really keen to know what people think about this. Because I know we do face Formageddon, don't we? If you go into EPR and forms everywhere, and again that's hard to manage as well. Something else, but if we think there's definite benefit, or at least we're uncertain, and we think a trial will tell us and put this issue to bed, then that I think would be really important to know too. So I might just leave that up there for a bit. Right. And then I think I'm done.